Hello, my name is Jack Ettinger, a health economist at the Health Economics Unit. I'm here today with Dr. Julius Ohrnberger and Dr. Anita Patel from IPSOS Mori to talk to you about discrete choice experiments and how they can inform resource allocation decisions. Julius and Anita will talk to you about what discrete choice experiments are and an example that we've developed looking at COPD before I talk about how that survey is being used to inform resource allocation decisions.
My name's Anita Patel. I'm a health economist at IPSOS, and together with my colleague Julius Ohrnberger, we're going to talk about using choice experiments to inform resource allocation decisions in healthcare. So we all know that resources available to deliver healthcare are limited in relation to the needs of the population. And this means that we've got to make some quite tricky decisions about how to allocate those resources to their best effect. And decisions about healthcare get made at various levels, starting from policy level at the top down to decisions at local services. And decisions also get made in lots of different ways. But a common factor is that those decisions around healthcare resourcing are often tough and quite complex. They're also naturally going to be influenced by who's involved and what perspectives they bring, and in other words, who's consulted or who's at the table when those kind of decisions get made. So clinicians and service planners naturally bring some relevant expertise to decisions about healthcare, but patient and public perspectives are obviously important because that's who they're about ultimately. So it's important to involve patient and public in decisions around healthcare, and there are different ways of doing this. Some kind of group approaches include deliberative engagement, which involves giving people a wide range of information to mull over and asking them to form some groups together, some views together. And choice experiments, which we're talking about today, are a way of engaging with people in a more individual way, and that's what we want to describe here. So what are choice experiments? Well, firstly, it's worth mentioning that it's a really well-established approach that's been used for many years. It's very commonly used in market research around new consumer products, but it's also used to inform public policy making. And it's a largely quantitative approach, so it brings structure to understanding the process through which people make decisions. And what the experiment itself actually involves doing is firstly, identifying the relevant considerations that surround a choice, and we call those attributes. And it also involves identifying how those attributes or considerations can vary, and we call those levels. So if we think about a very simple example, say we wanted to explore how choices are made about buying snack foods. So one relevant attribute or consideration could be nutritional value of the snack item. And another could be about the specific type of item that it is. So, for example, a red apple versus a green apple, that would influence somebody's choice. Those kind of considerations in a healthcare context, if we think about, for example, where we might locate a new service that's being developed, and a decision could take into account the locality of that service or the distance to travel for a patient, waiting times, and so on. And in a choice experiment, the process that we'd go through is working out what those relevant attributes and levels are for the choice that's being considered. And then we would present people with a series of choice scenarios, typically in pairs of scenarios, and each one of those represents a different combination of attributes and levels. And the choices that they make across all of these scenarios together, what they do is indirectly reveal to us as the analyst what their preferences are across different attributes. So how do these choice experiments help inform the actual allocation decision? Well, by analysing these structured choices in this way, we can understand how people might trade off improvements in one attribute against a worsening in another. And altogether, it gives an overall indication of the value that people might attach to different aspects of care. And by understanding preferences in this way, what we can do is take them on board when we plan services to make them more appropriate. And this in turn is hoped really to increase the chance that the care that's being considered will be more acceptable to patients and therefore more effective. So we use this choice experiment approach to help some regional service planners called integrated care systems to decide what mix of interventions they should provide for care pathways for people with chronic obstructive pulmonary disease. And the experiment that we've done and that Julius will describe shortly feeds into a wider process that combines a technical value for money analysis, which is based on various data sources, and lots of stakeholder engagement. And the choice experiments really are part of that stakeholder engagement to take some of those patient perspectives into account regarding their chronic obstructive disease care pathways. So now I'll hand over to Julius for him to describe exactly how we did that.
Thank you, Anita. That's really interesting. And I'm going to talk about how we developed the choice experiment, about how we disseminated it, and about some of the findings. But first, Anita said that the attributes and their levels are very important, the backbone of any choice experiment. So for us, a very first step was to identify the right attributes for the COPD choice experiment and to ensure that they were relevant for the patient population as well. So what we did first was to go through the scientific literature and composed a list of important attributes and their levels. Following that, we presented the information to a group of clinicians, researchers, and NHS managers from intensive care systems that took part in this study. They gave us feedback, and we came up with a final list of attributes and lists, which is a fundament of the choice experiment. You will see this list of attributes and their levels on this slide. What you see highlighted are the 6 attributes which we consider, alongside the clinicians, the experts, as most relevant for our choice experiment to inform how COPD patients want to prefer to access their treatment. The first attribute is the impact that the treatment has on your COPD, which the levels little relief, some relief, and complete relief. The second one is the way that you receive treatment sessions. The levels are online individual appointment, online group appointment, in-person individual appointment, in-person group appointment. A third one is the average travel time from a treatment appointment, including both outward and return journey, from up to 30 minutes to more than 60 minutes. Fourth one is how much you have spent on average to attend a treatment appointment, ranging from no out-of-pocket expenditures to more than £15. A fifth one is how long you need to wait for treatment after being referred. That ranges from up to 3 months to over 6 months. And the last and sixth one is the type of staff delivering the treatment. The levels of this attribute are healthcare professionals, non-healthcare professionals, and volunteer charity workers. Now that we identified the attributes on different levels, it's important to understand how these attributes and levels feed into the actual choice experiment. What you see here is a choice frame. Participants of the survey, those who are COPD patients aged 16 and older, they have presented 11 of such choice frames. They're always the same structure in the sense you always have the 6 attributes I just discussed, and there are always 3 options. Each of the option has a variation of the different levels connecting to the responsive attribute. What we ask the respondents to do is to choose the option they prefer the most. Only one option. Participants were also given the choice to select none of these. What is important to consider is that individuals, they choose the options collectively. By that, I mean the option engulfs all of the 6 different attribute levels. They don't just choose one attribute. They don't just choose one attribute level. It's all of them together. The 3 options they choose in this frame from are all equal in terms of the impact that the treatment has on their COPD, some relief. They vary in the sense that option number 1 offers in-person individual appointment, option 2 in-person group appointment, and option 3 online individual appointment. Accordingly, the average travel time to treatment varies between the options, also the out-of-pocket expenditures and the time they can access the treatment from referral. And these options, also all the staff delivering the treatment, are equal. These are healthcare professionals. So this is how individuals were given the choice set and were making their choices in terms of the choice experiment and enabling us to understand the preferences for attributes, for the levels, but overall for complex treatment options. Now that I discussed how we designed the experiment, it's important to understand how we disseminated it. We did this, well, the HEU did this with the support, with very strong support of 5 integrated care systems. These systems, as you can see on this illustration of England, are Nottingham and Nottinghamshire, Birmingham and Solihull, Coventry, Northamptonshire and Gloucestershire. Findings. It's all about preferences of the COPD patients. And this is based on the information which we got from the survey and the choice experiment. What we found is, with regards to the attributes, what's more relevant for COPD patients are treatment outcomes, treatment delivery, and who delivers treatment. Looking at the more relevant attributes and the levels, patients somewhat surprisingly preferred little to some relief of treatment outcomes over complete relief. We assume this is because it is a chronic illness and people have rational expectations of what is feasible to get from the treatment. Patients have very strong preferences for in-person individual appointments, and they want the treatment delivered by healthcare professionals. Less relevant with the travel time to an appointment, waiting time from referral to treatment, and out-of-pocket travel expenditures. What you've seen before were just the preferences for the attributes and the respective levels. Now, you're familiar with this slide. You've seen it a couple of minutes ago. These are again exactly the same options from the choice frame. And what we can do with the information gained about the preferences of individuals for attributes and their levels, we can understand how a population makes complex treatment choices. We can understand how those respondents in the survey choose different options. What we see at the bottom here are the preference shares. And this is similar to the preferences of the population, the support of the population for a complex treatment option. What we see here is that option 1 and option 2 are equally supported in the population, both having about 18.4% of preferences of individuals taking part in the survey. Option 3, which was the online individual appointment, has slightly less support. Now, why does this matter? Why is it important to understand? This information can feed into resource allocation, into local planning of service access here for COPD. For instance, because option 1 and option 2 have equal support in the patient population that took part in the survey, option 2 may be a preferred option because group appointments could potentially be cost saving to the service providers. Likely individuals access it closer to home, reducing out-of-pocket expenditure, and can access the service much quicker due to less required resources to deliver it as a group appointment. This is just an illustration though, hypothetical, but these scenarios help individuals, help decision makers to decide on how to allocate resources and how to improve treatment access for patients. And Jack is going to talk to you more about how these results feed into real life decision making at small local NHS levels. Thank you.
Thank you, Julius, and thank you, Anita. We have been using the results of this survey in decision conferences with the respiratory programs of 5 ICSs to help inform how we can better make our services work for patients. One example of a plan that is now being worked up following these decision conferences is how we can get healthcare professionals into sessions like pulmonary rehabilitation and peer support groups. The idea being, we found in the survey that there was a strong preference for seeing a healthcare professional when interacting with care services, and that this would, one, improve uptake to the services, as people will know they can see a specialist there, and two, help to improve the value of those services, as specialists will be able to do things like give advice on prescriptions and help to educate patients further on how to self-manage their own condition, which is really important for COPD and other long-term conditions. If you would like to find out more about this particular survey, discrete choice experiments in general, or have a question that you think discrete choice experiments can answer, please contact us on heu.support@nhs.net.